Good afternoon and welcome to today's IAC webinar, Performing Ultrasound Evaluations on Aorta Endografts. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you're viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and SVU. And now I would like to introduce today's guest presenter, Tammy Rubin. Tammy Rubin is lead sonographer for vascular surgery at the Cleveland Clinic Heart Vascular and Thoracic Institute in Cleveland, Ohio. She is licensed and board certified with RDMS and ARRT. She has served as an application reviewer for the IAC vascular testing and vein center programs, a true expert in the field, and we are happy to have her with us today. And with that said, I will now turn this webinar over to today's speaker, Tammy Rubin. Tammy?
Hi, thank you, and thank you everyone for joining in on performing ultrasound evaluations on aorta endografts. This talk is going to cover endovascular aneurysm repair, our role as sonographers, the IAC standards now that the IAC is accepting EVAR studies for accreditation. We're going to talk about scanning techniques along with interpretation and reporting and contrast agents. Endovascular aneurysm repair has emerged as an increasingly important treatment modality in patients with aortic aneurysm when anatomy is suitable. EVAR has become the main treatment for abdominal aneurysms over the last 20 years. We know it's less invasive and has a faster recovery time. An endovascular stent graft is a fabric tube supported by metal wire called scaffold, and it has a Z appearance in it. The endograft is sealed tightly above and below the aortic aneurysm, allowing the blood flow to pass through the graft, excluding the aneurysm sac from blood flow. And here's a diagram animated of what a stent graft looks like. Again, placed in the aorta above and below the aneurysm, allowing the blood flow to pass through. For vascular surgery, when they do this procedure, the stent graft is introduced into the aorta through incisions or percutaneously in the patient's groin. The catheter guides and delivers the stent graft through the blood vessel to the site of the aneurysm. It is then deployed between the 2 healthy portions of the aorta. The stent graft then realigns the aorta and seals off the aneurysm sac. All of this is performed under fluoroscopy, which guides the surgeon a placement of the stent graft in the correct location. And here we have another animated diagram showing us from left to right, the catheter being placed into the right groin and a catheter in the left groin with the middle image of the stent graft being deployed, then the contralateral limb being deployed and sealed. And we're going to go through a couple more x-ray images as well. So this is what the device looks like. Again, it has that Z appearance, the fabric tube with the Z appearance of the scaffold wrapped around it. And this is actually a stent graft for a juxtarenal AAA. We have the proximal body, then the bifurcated body, and then the contralateral limb. So under fluoroscopy, you can see on this top image the catheter being placed with the stent graft being introduced and a guide wire in the contralateral limb. And here, again, they're starting to deploy the stent graft. This image is showing the proximal body of the stent graft being deployed and the appearance of the wire. And over here we have our completed x-ray, which is a DSA. It's digitally subtracted, so there's no bone in this image, showing the blood flow coursing through the stent graft, excluding the aneurysm sac. And here we're not seeing any perigraft flow or endoleak, which we're going to get into a little bit later. So again, the stent graft is deployed into the disease segment of the aorta, and it realigns the aorta like a sleeve, diverting the blood flow away from the aneurysm. So as sonographers, to perform this study, there's a few things that is extremely important to have. It's important to have the operative note. So if you know these studies are on your schedule and you're not in a lab that is working right next to your clinic of doctors, it's important to get the operative notes and review them. And when you're reviewing the operative notes, these are some helpful hints. You want to look for keywords, making sure that endovascular repair is noted in the operative note. And that's actually basically what you see in every operative note. If it's endovascular, if they've had an EVAR, it's going to say endovascular repair. It's going to describe what brand of device that they used. And the common ones that we see are the Cook, Gore, Medtronics, and Endologics. You're also going to read in the operative note the location that's treated. All that information is very important, and it is actually required on reporting for the IAC that you have this information in the body of your report. Most important with the operative note is looking for the completed angiogram. Every patient that has an endovascular stent graft placed, whether it's an EVAR or a FEVAR, a branched, they have a completed angio at the end of the procedure to rule out endoleak and to look for alignment of the stent graft. Very helpful to find that. And usually you see that in the last paragraph of the operative note. Another helpful hint is to, review prior imaging. If you can see, and if you have opportunity to view angio, that's helpful. The CAT scan report, if you are able to review CAT scan images, even better. So you can see what your residual aneurysm sac looks like, tortuosity, whatnot, along with prior ultrasound. It's helpful if you have the opportunity to review those. Another important part of performing this study is to get a good H&P. You need to have conversation with your patient. We get a lot of patients from outside facilities, either for revisions or complications or just new to the area, what have you. And we don't have any information on them or prior studies. So it's helpful to have good conversation with the patient, look for incisions. Having a good conversation and getting a good history not only builds confidence in the patient that you're comfortable with the study, and for you that you're going to be able to execute it. So our role in performing these exams is to evaluate the entire aorta. We're going to look proximal to and distal to the stent graft. We're also going to look for patency throughout the stent graft and its limbs. We're evaluating that residual aneurysm sac, making sure it's decreasing in size. If there's an increase in size, that's going to be suggestive of an endoleak. That's kind of a red flag for us. And also our role is to, rule out perigraft flow or endoleak. Now we're going to go into the required images for these studies with the IAC. So required grayscale images, we're still doing our sagittal and transverse images, but additional images to what we do for a normal aorta duplex is evaluating that residual aneurysm sac. And we're going to report the widest diameter that we measure. And here are the specifics on these images. I'm going to actually go through them individually with slides explaining what we're going to take. So we're going to start out evaluating the aorta proximal to the endograft, either proximal aorta at the renal level. The IAC recommends one or the other. Our lab, we always evaluate both segments. Our surgeons prefer to know what's going on right proximal to the attachment site. Next is you're going to get a grayscale image of the mid-aorta at the attachment site. And this image just is a nice image showing the proximal attachment site along with the limbs. We're going to obtain measurements of the residual aneurysm sac showing the endograft in sagittal or longitudinal and transverse. We're going to obtain another diameter measurement at distal. Again, what's going to go on the report is the largest diameter. We are going to also take the distal attachment site. And here on the left, we have the left limb distal attachment site. And in transverse, this patient's we've changed positions into decubitus so we can see the limbs in transverse as well. And most importantly, we're going to evaluate the outflow vessel by measuring to ensure that there's no aneurysm distal to the endograft. Now on to our color Doppler and spectral Doppler images. So everything we just looked at in grayscale, we're going to go ahead and capture a color and a spectral Doppler as well. All those locations, proximal to the endograft, the mid-aorta endograft, each limb of the endograft, and the outflow vessel, which is usually the common iliac artery. However, if they have limb extensions, it may be the external iliac artery. We're going to also evaluate the residual aneurysm sac in color and power Doppler. And this is important when you're doing your images of the residual aneurysm sac looking for endoleak. It's important to be specific on your labeling for location. Whether you're in supine or decube, it's always good, of course, to label sagittal or transverse, and where exactly you are at that location, like distal at the limb bifurcation. This is really important for not only the next person that's going to be following you, but if the surgeon needs to go in and treat this patient and the patient is not able to have a CAT scan, this is going to help them identify exactly where they need to go in and treat the patient. Also, if the patient has a stent graft, has a branched endograft, like a EVAR, the branched vessel needs to be evaluated as well with grayscale color and spectral Doppler. And here we're just going to go through these images of exactly what we did in grayscale, again, obtaining our spectral Doppler. It's proximal to the endograft, either proximal or at renal level. Mid-aorta, which is the proximal attachment site of the endograft. We're going to evaluate the limbs. So this patient had a limb extension. So the limb travels, normally we just obtain one spectral Doppler in the limb, but this limb extended throughout the entire common iliac. So we walked our Doppler all the way through that. And you might think these images are a little, not textbook perfect, but we're at 10 centimeters deep. So this is a little bit of a challenging exam. But they're parallel to the flow, and there are no velocity shifts. So next we're going to talk about the scanning techniques for grayscale, color, and spectral Doppler. And these are some suggestions that are going to hopefully help with your image quality and seeing what we need to see on these studies. So we know that our lab is a multi-vendor lab. And we know most vendors are striving for specific solutions on particular studies to have their optimal grayscale. So they're trying to improve spatial resolution. So this is where you need to talk to your application specialist and learn your knobology on your machine, because each machine has different features that are going to be for grayscale optimization. Always review your equipment manual or visit the vendor's website on their specific features to that vendor to help you know what will help your image quality. Always start out with using the vendor's preset, then you can adjust it and customize it. Make this preset specific for your study. In our lab, we have presets specifically for every single study that we do. That way, when we pick this preset, our color comes up, the PRF is set exactly, the box is angled correctly, it's grayscale optimization, it's wonderful. So communicate with your application specialist, they're here for you. One suggestion that I can say that's universal on all machines is the dynamic range. We know that these stents are a very highly reflective metal. Decreasing your dynamic range will help you see your attachment sites much better, along with your residual sac walls. So most vendors, their preset on the machine, the dynamic range is usually set around 70. We like to bring ours down to around between 50 and 60, and you may think that's really low, but once you see some images that we're going to go through, it's very helpful when visualizing the stent wall attachment sites along with the residual sac wall. Also, your chroma maps, changing the chroma colors, as you've seen a couple of images we've already displayed, has helped us appreciate those posterior walls a little bit better. If you feel like you're getting artifact and you can't get rid of artifact in your image, lower your output power. That's always a go-to there. So here we have the use of the chroma map on a decube image of the aorta, and you can see this study is like at factory setting. Honestly, it's a beautiful preset. This is honestly a great patient. We're only about 4 to 5 centimeters deep. But changing your maps, being aware of your dynamic range is really helpful. This patient had an endograft several years ago. Here we dropped our dynamic range down to about 60, so you can see the outer wall a little bit better. And this is actually what an endograft looks like several years out. Usually your widest measurement of the residual sac is at the limb bifurcation. So now for scanning techniques for color, power Doppler, and directional power Doppler. So these suggestions are specifically for looking for endoleak or a patient that may have low cardiac output or just slow flow within the aorta. What is helpful is to lower your PRF. And on most machines, the knobology, it's going to be your scale so that you're lowering your pulse repetition frequency. My suggestion is to increase your persistence to high or maximum. That'll help hold that color there longer. Again, each vendor has maybe a different term that they use for persistence, but I encourage you to increase it. It's going to keep that color there a little bit longer. It's going to kill your frame rate but that's okay because you want to catch these endoleaks. The most common endoleak that we see is the type 2, which we're going to talk about that again a little bit later. And these are the hardest sometimes to pick up because they're little feeder, little branches, either a lumbar or a collateral, and they're hard to pick up. And this will help hold it there. You want to, you can lower your wall filter and your line density. Adjust your right priority and your overall gain. You can visually see how that works for you. We know that the stented aorta and the visceral vessel and the limbs have acute angles and it may be difficult for you to have your color fill. That's where you want to go to your power Doppler. And if your machine has the directional power Doppler, it's a must. It's a lifesaver. We know power Doppler is extremely sensitive in detecting blood flow. Putting the directional Doppler on is going to allow you to pick up direction of blood flow, maybe help characterize an endoleak, along with obtaining your spectral Dopplers with the use of directional power. And here's just an example, just an image. This patient had very low cardiac output, supine, we were not getting good color fill. Turned the patient into cube, used our directional power, filled lovely. So scanning techniques for spectral Doppler. I think this slide is pretty much universal in what we do on every vascular study when we're obtaining spectral Doppler. We're keeping our sample volume between 1.5 to 2 millimeters. We're Dopplering at an 60-degree angle or less, center stream of the flow, parallel to the vessel walls or the stent walls. During abdominal work, we know that you have to manipulate the probe heel toe a lot to achieve that 60-degree angle or less. I didn't go deep on what probe to use. Everybody that is probably listening to this talk with abdominal work, you know you're going to use a curved array or a phased array probe, so specifically for these studies. Heel toeing is the key for these studies into achieving a 60-degree angle or less. Your Doppler signal should be multiphasic throughout. So here is just a spectral Doppler parallel to the flow. Now for reporting criteria. We're going to talk about everything we just looked at and took pictures of. We're going to document whether there's an aneurysm proximal to or distal to the stent graft. We're going to document whether there's a degree of stenosis throughout the aorta, the stent graft, or the outflow artery. Again, we're going to report that largest diameter of the residual sac and the location. We're going to also report if there's any endoleak. Characterizing the endoleak is not always easy, but if you can, that's very helpful to the doctor and treatment options. But if you're unable to characterize the endoleak, that's okay. Just report that there's perigraft flow visualized, unable to characterize endoleak, may wish other means of evaluation. They're not always easy to characterize, but if you see a leak, you should definitely label specifically where you are and what plane you're in, along with patient position. The IAC required reporting is requiring the proximal and distal points of the endograft. If there's an endoleak, what type of endoleak? And again, that's not always possible. If the patient has had intervention, treatment for endoleak, that should be under the indications. And most importantly, you should always compare to your prior study on your report. So for example, this patient had embolization for a type 2 endoleak. That was a procedure. At the end for your reporting, Prior exam noted endoleak. Today, successful coil embolization. In our lab, our Doppler criteria, I wanted to put it up here for you, and a reference for our EVARs and our branched endografts for the limbs. So we report patent if there's no evidence of plaque or increased velocities. If there is plaque without a hemodynamically significant stenosis, that's another option. A 50 to 99% stenosis is a doubling in PSV across the aorta with plaque visualized and post-stenotic turbulence. For our common iliac and the endograft limbs, if the PSV is greater than 300 centimeters per second, along with turbulent flow, post-turbulent flow, we report that as a 50 to 99% stenosis. So next we're going to go into the branched endografts, the fenestrated endovascular aortic aneurysm repair, EVAR. Years ago, or not long ago, it was referred to the fenestrated. Commonly today we see these endografts as reported as a branched stent graft. And what it is, it's a specially designed custom-made graft which has holes, which are the fenestrations, on the body of the graft to maintain patency to certain important blood vessels. Again, another animated diagram where you can see the fenestrations, the hole in the stent graft, and this is the proximal body fenestration for celiac, SMA, and both renals, and then a multi-branched endograft. And then here we have a uni-branched for the hypogastric. So this is an EVAR with a branched, it's considered a branched endograft because they're stenting the hypogastric. So this is what the stent graft looks like. This one is for a juxtarenal AAA. So, sorry, I got stuck there for a second. So actually we have a scallop. This is scalloped. So this will snug right up against the SMA. And then you have the fenestrations for the renal arteries, and then the body and the contralateral limb. And these little markers are the radiopeg markers. So under fluoroscopy, the surgeon is able to know if they're AP, the positioning of the stent graft. So that guides them. Again, IAC standards, if you have a branched fenestrated stent graft, that branched vessel needs to be evaluated. You want color, spectral Doppler, and grayscale image. So here's a CTA reconstruction of a branched endograft of fenestrated. And actually it's a TVAR and a FEVAR. So before surgery, after surgery, so you have the thoracic branch, then your fenestrated branch, and it actually ends in infrarenal at distal aorta. So we have our very tortuous celiac, SMA, and then your renal artery stents. And this is a female because you can tell the way she's standing. Okay, so for ultrasound, we have the study to go right along with that CT. We're measuring the residual sac, and this is actually a proximal. And then we're showing native vessel outflow, distal aorta, which is distal to the stent graft. We also evaluated the celiac all the way through. It's very tortuous, but we were able to obtain spectral Dopplers throughout the stent, showing for patency, along with the SMA. And then here we have our right renal artery stent, just grayscale, and the power Doppler. Excuse me, for the left renal artery stent, here you can see we went to the directional power Doppler to get the color to fill throughout. And like I said, you can, obtain spectral Doppler. It's very, very helpful with these studies, the directional power angio. So when you're evaluating these branched endograft, My suggestion is follow your department's protocol, whatever their interpretation criteria is. Now we're going to go into endoleaks. The highlight of this study, this is what we really want to do and investigate. So an endoleak is defined as flow into the residual aneurysm sac post EVAR, FEVAR, or TEVAR. An endoleak is a complication that affects about 15 to 25% of patients who've had endovascular aneurysm repair. And there are 5 types of endoleaks. We have our definition and our diagram here, but I'm going to talk about each one specifically and review this. So a type 1 endoleak is an incomplete seal or ineffective seal of the graft. It occurs at the top or the bottom of the stent graft, and they're referred to as type 1A at the top, or type 1B is when the leak is at the bottom. These types of endoleaks are typically treated with a greater sense of urgency. So we have an animated diagram along with a CTA, excuse me, not CTA, a CT with contrast, and this is the AP view, and you can see the flow outside of the stent graft, and our cross-sectional image showing perigraft flow around the stent. On ultrasound, you'll see, we don't see these very often, quite honestly. The type 1s, we see type 2s a lot. So here's a spectral Doppler and then our color Doppler. And again, our color scale is at low. It's like at 15, our PRF. We have our dynamic range at 55, which is good. You can see the outer wall here and the attachment of the stent graft. So just doing these optimization cues will help you achieve a good image. Here we have another type 1, and over here, one of our vendors, we have B-flow. And the simple way to describe B-flow, it's just grayscale inversion. Over on this side, we did a image compared with the directional power to pick up this slow flow and a spectral Doppler as well. Like I mentioned, type 2 are the most common type of endoleaks that we see as sonographers. Blood flows into the treated aneurysm sac from small branches of the aorta or other blood vessels. They're seen as retrograde or bidirectional flow. Again, it's native artery feeding that aneurysm sac, and it's either the IMA, your inferior mesenteric artery, it could be a lumbar, an accessory renal, collateral arterial branches, or internal iliac artery. And again, type 2, showing our little diagram along with, you can see the blood flow into the aneurysm sac, and this is a cross-sectional CT with contrast. And here we have a type 2 endoleak from the IMA showing the bidirectional signal here, the to-fro flow. So if you're picking up a to-fro flow, it's like the track signal that you see with a pseudo. Here we have another endoleak, power Doppler, color, spectral Doppler. We know there's a leak. We have all this bowel gas in the way, trying to figure out where is this leak coming in. Is it a type 2? Well, here we decided to move the patient into cube. And here, moved the bowel gas out of the way, and actually we were able to get even a much more accurate measurement of the residual sac. I know I mentioned to label specifically on your images, and I think we could do better at that as well, but it's extremely helpful. What's our location here? So with moving this patient into decube position, we were able to characterize this endoleak as a type 2. So it's really important. You definitely need to look at these residual sacs, both in supine and decubitus position. And again, if you're getting a discrepancy with the patient in supine position, in your measurements, we're kind of close here, 5.8, 5.2, 6.2. Turning them into cube, here we were much more accurate with our measurement. Now we're going to go ahead and talk about this fenestrated stent graft with the endoleak. They have the right renal artery is patent. You can see something filling up here above it. So we threw a Doppler in it. We've got our PRF low picking up. That's why you're seeing all this aliasing. Backing up, oops, our scale is optimized for this renal artery stent evaluation. Now we're investigating this little branch. Picking up that 2-fro signal. Here using B-flow, we were able to pick up this tiny lumbar filling in, and with spectral Doppler showing the 2-fro flow. And this little branch is just superior to the right renal artery stent. Then just below that, moving down on this patient, we were able to see another endoleak, but this was actually antegrade flow. It's still an endoleak because there's a branch outside of exiting the aneurysm sac. So it's going, our flow's going away, our Doppler negative going away and negative. So it's actually an antegrade branch, flows coming in and going out. It was a very fun study. And again, another image showing that branch. So type 3 endograft is characterized as a defect or misalignment between the components of the endograft. It's referred to as component separation, graft disconnection, disintegration, or a fabric tear. And here's what it looks like on ultrasound. When you have a fracture or a break in the graft, you're going to have a lot of anechoic flow, fresh, frank blood into that residual aneurysm sac. And here you can see it layering. We have partially thrombosed and flow into the sac. And here we have the color Doppler and our power Doppler picking up that slow flow and that type 3. And here we have one with a fenestrated stent graft where there's a fractured left renal artery stent. And spectral Doppler, and then within the aneurysm sac as well. A type 4 endoleak occurs when the blood flows through the pores of the stent graft. And typically, we don't see these at all. With these newer generation stent grafts, I've never seen a type 4 endoleak. A type 5 endoleak is known as endotension, and this is where there's an endoleak of unknown origin. There's the residual sac is increasing in size, but there's no visible leak on CT or duplex ultrasound. And I've seen this a couple times. It's very frustrating. So in summary, surveillance of endografts post-EVAR or FEVAR should be performed in the supine and decubitus position. This will ensure that endoleaks have not been missed. Again, characterizing the type of endoleak is helpful, but not always possible. And you just report that, like we said, unable to characterize type of endoleak, may wish other means of evaluation. Like we mentioned, type 1 and type 3s are typically treated with a greater sense of urgency. Type 2s can be monitored and managed if there is not an increase in the aneurysm sac size. So in summary, the scanning techniques for assessing for endoleaks. If you have these special features on your machine, you should use them. Some things to be suspicious of: if you're seeing a residual aneurysm sac that is not completely thrombosed off and there's anechoic areas, you should be very suspicious of endoleak. And here with the B-flow picking up the red blood cells, this anechoic area is not filling. And then, do your cine loop sweep. Nice and slow. Set your sweep speed to about 10 to 15 seconds, and just do some slow sweeps, not only with your color Doppler, but use your power Doppler as well. And don't forget to take still images too. So one of our other vendors has this microflow imaging, the MFI, and this is also very helpful. It picks up low blood flow as well. So we can see that there's an endoleak on this patient. And they just did, tech just did dual screen, color, and then MFI. And then here we can see perigraph flow into the aneurysm sac. Again, just cues on your PRF, low color scale, or dynamic range. Here you can see the stents really well, the limbs of the stent graft, and your posterior wall. This patient had a type 2 from the IMA, showing the bidirectional flow. The patient went on to have coil embolization, and here on the fluoroscopy, you can see all the coils in that IMA, and there's no flow into the residual sac. The angio showing the dye excluding this area, and then again, our ultrasound showing the coils here. They're really bright, just like the stent walls. Again, keep talking about when you investigate for perigraph flow, you want to make sure your PRF is low and, optimize your dynamic range. And here we have a cine sweep showing those bright echoes of the coil embolization and the thrombosed residual aneurysm sac. Again, low PRF, power Doppler, and color Doppler spectral on this endoleak. So this was a low flow. Look, we're only about 40. So we picked up this little branch feeding this endoleak, and our power angio is set at 650 hertz. So when you use your color power or your power Doppler imaging, sometimes the presets on the machine, when you hit your CPA or your power Doppler and it's all over the place and you're not sure which way to go for optimization, a suggestion is set your PRF to about 2000. That's going to give you a baseline on any study that you do. And then you can go up and down from there, adjusting for optimization. Same with your color. Moving on to contrast-enhanced ultrasound. Contrast agents approved for vascular ultrasound use. Reports and literature suggest it may be useful in detecting endoleaks. Our lab does not find it necessary to use them. If your lab is using contrast-enhanced ultrasound for endoleaks, images must be obtained at the location of identified endoleak or potential endoleak. In summary, duplex ultrasound can be a useful tool for follow-up after EVAR or FEVAR for evaluation of branch patency, stenosis, residual sac, and and endoleaks. Careful attention to known anatomy based on other imaging modalities such as CT and sonographer persistence can result in accurate diagnosis of endoleaks. Duplex ultrasound requires a skilled sonographer with knowledge of endoleaks and aortic pathology. The more studies you do, you're going to continue to improve your skills. So if you have the opportunity to scan these patients or even back scan after somebody else, you're going to improve your skills, and it's rewarding doing these patients. It's fun. Use of a structured protocol to image all components of an aortic stent graft and branch stent graft is extremely helpful. So our lab uses structured protocol, and like I mentioned before, we use custom presets, but using a A structured protocol will aid in obtaining required images for accreditation, improve your consistency amongst your team, and image quality, along with reducing human error. You're going to continue to obtain the correct images on every study. The reader that's going to be reading these studies is going to be thrilled because every study is going to follow the same routine. Again, talk to your application specialist. They will assist you in setting up a structured protocol. And again, you can just open your manual or go online and pull up the website, and they're very easy to do. We customize all of our protocols. And a persistent sonographer who is willing to use multiple patient positions and spend time to optimize images can make an important contribution to patient care. Thank you, IAC, for inviting me to do this talk, and our vascular lab for all the fabulous images we were able to share. And this team of doctors that I've worked with over the years have given me the confidence and the experience on these studies. And our entire vascular lab, along with the Cleveland Clinic image. And this is our team getting through the last year with our pandemic. Thank you so much.
Okay, thank you very much. And at this time, we will begin the Q&A session. From IAC Vascular Testing, I'd like to introduce Marge Hutchison, our Director of Accreditation. She will be assisting with the Q&A session today. Marge, would you like to start us off?
All right, thank you. Thanks, Tammy. That was an excellent presentation. A lot of questions are here. I'm going to try and do it somewhat systematically. The first question is, or there's several questions about does the patient have to do anything pre-procedure, as if it was a renal case or something like that, like MPO or anything like that?
That's a great question. Honestly, I didn't go deep on patient prep. I specifically geared this talk for everyone, assuming, which I probably shouldn't have, that everybody is already doing abdominal studies, and we of course recommend them being NPO for the exam. However, that's not always the case. In our facility, we scan abdominal studies all day long, whether they're NPO or not, depending if it's the mesenterics, your celiac and SMA. Of course, that has an effect, but yes, NPO is important.
Okay. The next questions are, there's several again, regarding positioning of the patient. You talked a lot about decubitus. Some people don't know what that means. And some people don't know whether you mean right or left, or whether you routinely do that as part of your procedure or only when it's felt to be needed. Can you kind of talk about that positioning a little bit?
Sure. So we image supine and in right lateral decubitus. It helps move the bowel gas out of the way. It's helpful for these studies, especially when ruling out perigraft flow. So that's very important to change positions. I'm just kind of going back through the slides and looking for a couple of the decube positions showing I think I had where the bowel gas moves and we were able to see the walls and the entire residual sac. Our protocol in our lab is to image in supine and decube, looking for an endoleak specifically. It's very helpful. And if you are able to get an accurate measurement in decubitus, that's helpful too, to use that size measurement.
Okay. There's another question here about scheduling the patient. How long does the average exam take, and what does it involve in that regard?
Well, the exam, our time slots are booked for an hour. So it may take a little bit longer depending on your experience. what does it entail? Everything we just talked about, we're going to be taking for, if you're submitting these studies for accreditation, for your required grayscale, your color and spectral Doppler, along with your images evaluating for endoleak.
Okay. There's a question here about diameter measurements. They're wondering whether you do inner wall to inner wall or outer to outer. What's your standard there?
Oh, it's outer to outer, and maybe we missed that backing up through these slides. It's on the IAC requirements, which it may have gone fast, and I apologize. So we'll go back here, our scanning. Sorry not to make you nauseous, buzzing through these images, but our sagittal and transverse images, measuring outer wall to outer wall, the largest diameter. This is a requirement for not only for aortic studies, but for these endografts as well. And you want to make sure you're perpendicular to the long axis of the aorta.
Okay. Sorry.
No, that's great.
The next question is, you stated that native aneurysmal sac should decrease in size. If the native sac remains stable or unchanged, is this still considered normal?
Okay, so it's not native sac, it's residual sac, because now the stent graft is placed within the aorta, excluding the aneurysm sac. So we're reporting this as residual aneurysm sac. If we're reporting aneurysm, it's going to be proximal to the endograft or the outflow vessel. That would be native vessel for aneurysm.
Okay, there's questions about, you mentioned stenosis in the distal part of the graft near the iliacs, and they're wondering how you determine percent stenosis at that level.
So another great question. Stenosis within the stent graft is a doubling. That's how we determine it. I'm not sure what your lab would, their lab would do, like for a regular or a normal native aorta study, but we base ours exactly on a native aorta duplex. If there's a doubling across the aorta or the main body of the stent graft, we call it a 50 to 99% stenosis. I'm going to buzz down to that slide because in our lab for the iliac limbs, or the limbs of the endograft and native vessel, a 50 to 99% stenosis is with a PSV of greater than 300. Just a moment. Here we go. So this is what our lab follows for calling stenosis within the aorta and within the limbs or the common iliac arteries. So doubling across the aortic segment or the stent graft, showing, of course, if there's a defect, thrombus, thickening, and poststenotic turbulence.
All right. There's questions about, when you're doing this procedure, do you ever take time to evaluate the kidneys or the lower extremities or the ABI or any additional parts of the system?
Well, another great question. If it's an EVAR, an endovascular aneurysm repair below the renals, we're evaluating a normal aorta. If the ordering physician requests ABIs, we would of course do them, but it's not routine. We don't schedule studies that aren't ordered. So, hold on. So we're, I'm sorry, Dr. Lydon just walked in. Hello, hello. Branched endograft. So if the kidneys are stented, just like the IAC guidelines, if you have a branched endograft where they've stented the kidneys, yes, you're going to do add your renal duplex to that. as the same with the fenestrated with the mesenterics. Like I showed the images, walking through the entire stented vessel. Sorry, I got distracted there a second.
That's all right. So you mentioned that you do not use contrast in your facility. Is that because you have this multi-vendor equipment, or what's the reason why you don't use contrast?
I really can't speak on that. We've just never found it necessary.
Okay. I'm going through the laundry list here. I just want to remind everybody that I have a lot of requests for look at this slide, look at that slide. The slides are now posted in the resources section, and you can download those for your own use. So those people who are requesting certain slides, you can get them right there.
Thank you for taking the time and wanting to review the slides again as well. That's great. Hopefully this is helpful and maybe can give you some parameters to follow when imaging these patients or these specific studies.
When you talked about the patient fasting, how long before the scan do you ask them to fast?
I would follow whatever your protocol is for a native aorta duplex in your facility.
Okay.
I mean, ours, I believe, is midnight the night before. But again, our facility, we scan all day long, even when they're not NPO. It's helpful, but not always an option.
Somebody's commenting here, and I noticed this too, that Bernie Sanders was in your vascular lab having a
He
test.
made his way to Cleveland.
Yeah, I saw that.
I'm glad you guys enjoyed that. It was a detailed talk, tried to add a little humor.
There you go. There's a few questions here about the residual sac.
Okay.
And people are concerned about whether it shrinks or doesn't shrink, and are they missing something if they don't notice any changes in it?
Okay, that's a good question. Another great question. The whole purpose of this stent graft is to exclude the aneurysm sac, so it should be getting smaller. If it's not getting smaller, then it could be, and you don't see a visible leak, it could be a type 5, which is the endotension. So there's no visible leak on ultrasound or CAT scan, but the residual aneurysm sac is enlarging. Typically, when these stent grafts are placed, this aneurysm sac is going to shrink over time. And I showed an image that a patient was several years out. Let me kind of back up to the beginning, that it shrinks and wraps, gets so small that all you're seeing is the device. Here we go. So this patient was several years out. So your largest measurement on these specific studies, when they're several years out, the aneurysm sac is going to be at the limb bifurcation. That's where you're going to see maybe like a little bit of residual aneurysm sac here. If you're up over a little bit higher, it's just going to be attached to that main body of the graft. So here's again, the images that are required by AAC. When you're taking your widest diameter, you want to show the endograft in your image. And here's our, sagittal and transverse. And honestly, the patient imaged really well into cube. Actually, that position is a lifesaver on almost all the studies we do. Any renal study, I feel like we scan our renal arteries with a patient into cube. It's less pushing than the patient being supine, and it just seems easier. All the bowel gas and the belly seem to roll out of the way.
All right. Well, as usual, this was an excellent presentation. I appreciate your expertise. It was very, very helpful. A lot of people had questions, and we did not get to them on the webinar here, but we will email you within a couple of weeks with the answers to your questions. So don't feel like your question was ignored. I'm going to turn it over to Kelly now.
Okay, thank you, Marge. And thanks again, everyone. And a very special thank you to Tammy Rubin for her presentation today.
My pleasure.
We're happy to have you. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Performing Ultrasound Evaluations on Aorta Endografts, EVAR. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.